Live.
You're welcome, folks. This is House Corrections and Institutions Committee. It's Wednesday, April 29th. It's our 10:30 meeting, and we are following up on some previous conversations we had when we were working on House Bill 550, which dealt with equity within our correctional system. And one piece that really needed a lot more work than we had time for was really looking at the healthcare system within DOC. And how healthcare services are provided to folks who are transitioning. Either they've come in under HRT, and how is that continued? Or they are beginning HRT during their time while they're incarcerated. What's the process there? What's also the process for folks as they re-enter the community and the connection with their healthcare provider, or continuity of healthcare services, and also just the general work that WellPath does with folks who are transitioning or are going through their own gender identity process. So we just wanted a deeper conversation here when we had a little bit more time and we could focus in on this. So I'm going to turn it over to Dr. Uliger first, and then we can go from there. So if you could introduce yourself for the record, and also you did bring someone with you from WellPath as well.
Yes, so Dr. Jim Uliger, the statewide medical director for WellPath, contracted through the Vermont Department of Corrections. And I have with me Dr. Morrison, who's our assistant state medical director, which is lovely to have a partner in this whole affair, because being the only one was a challenge. And so if this committee had anything to do with the ability to have an assistant, that's fantastic. And I did bring Dr. Morrison because he has a little more community experience with gender affirming care than I do. So Dr. Morrison, do you want to introduce yourself?
Yeah, hi, my name is Jeremy Morrison. I'm the assistant statewide medical director. And I'm board certified in family medicine and addiction medicine. And I have done a lot of gender affirming care in the community. I worked at Grace Cottage Hospital before here, and then in Brattleboro and Putney.
So your position, Dr. Morrison, are you connected with WellPath, or is this a separate position that you have within state government?
I'm employed by WellPath.
You're employed by WellPath.
Mm-hmm.
Just to be clear.
Yeah, thank you. And I wanted to, so I got two versions of the bill, and I just wanted to make sure I understood, and forgive my legislative competency or lack thereof. But I got a 14-page bill that's draft 4.3, and then I got a draft 1.3. I'm assuming it's the 4.3 is the one that we should be using.
Well,
14.
1.3 has the language that we have postponed. 1.3 has the medical care of inmates section 6 and 1.3 that we ultimately pulled out and replaced it with kind of a bookmark in the 4.1 or 4.3.
Look at the dates on those two drafts. So it would be the later date.
Well, the later date is what's currently in the Senate.
Right.
We're wondering, can we kind of bring back the components of 1.3 as this comes back to the Senate? If it comes back to the Senate, will we have any opportunity to reinsert this, what was section 6 in draft 1.3 in an amended format, right? Based on your input.
Yeah, okay. And that clarifies a lot, because the 1.3 seemed like an earlier version. So I was going to the 4.3, but I couldn't find my part in that. And so what you said makes total sense.
Okay.
And so just to review from a big lens what kind of my point of view in this particular piece of legislation is, and I think it's part of some of this committee's too, is, you know, we saw Kalani's testimony. we want to make sure that that type of experience doesn't happen. And so it sounds like, we want some legislation that kind of makes sure that provides a person like her some protections. And that based on our conversation last time too, we wanted to make sure though that language in whatever bill was not putting us in a position where we had to do something that we thought was a bad decision for whatever reason, for based on medical standards. The medical standards in the community are very affirming, but when you're dealing with people who've hurt other people with their gender, there's this whole challenge, right? And so that's a kind of nuance. And I went through, so it was the version 1.3 on page 11 that Dr. Morrison and I went through earlier today. And this feels very good. Like we could not find anything, like we feel like it's asking for access to gender affirming care, which really we're held to a community standard. And in this community, that's community standards, having access to gender affirming care. So access is a great word because we don't have to, like, if it's not indicated, we don't have to do it, right? And which is fair. And I'm not trying to deny somebody their care because we're trying to meet the community standard. The one challenge that just with this, and this is a very minor thing, but access, there's only, like, it should be access that's similar to community access might be the only thing, because there are things like right now we can't find somebody to do electrolysis. Like that person just doesn't exist, or they didn't. If somebody exists now, they didn't a few months ago. So like, how do we, or does that put us in a difficult place legislatively? But otherwise, this feels very benign, and it achieves what I think is the preventing the horrible experience that somebody like Kalani had, but still gives us some, prevents us to having to refer somebody for surgery who knows Dartmouth, for example, is not going to do surgery on because they don't meet the, and I'll stop there because I don't have a lot else to add. I'm very happy with this.
Kevin?
I'm having a hard time hearing. It's probably my hearing,
No,
not your
it's-
speaking.
You were cutting in and out, so I had a hard time.
You
sorry.
said Dartmouth does not do the surgical procedures?
No, that's not, my apologies, and I'll speak up and maybe that will help. I wouldn't want to have to, by legislation, refer somebody to a surgery that I know that, for example, whatever center it is, isn't going to do because the person will not meet the criteria.
Right.
Whatever those criteria are, and I feel like we have enough discretion with our clinical judgment in this while it's also providing protections.
So it's
I
not
think this
saying Dartmouth won't do it. It's, there's
No,
certain
no.
qualifications that need to be met.
Yeah,
Dartmouth does do surgery, those types of surgery, but there's certain
Absolutely.
qualifications that have to be met. And if those qualifications aren't met, the facility will not do the surgery.
that's right. There has to be a certain consistency of the symptoms and whatnot. I'm not expert in this. Dr. Morrison may know them more specifically. But those are the kind of things that I didn't want to be shoehorned into kind of having to provide if they weren't consistent with good medical care. And we absolutely want to prevent something like what happened to Kalani. And I think this totally does that. I don't have a lot to add.
From your read of the bill, are we covered, or maybe even with existing statute, are we covered from a continuity of care sort of perspective that somebody who's showing up already on HRT, let's use that as an example, do we need to include anything in here that isn't already covered by existing statute on continuity of care? I'm also then curious about what if, so, and to use Kalani's example, right? She told the story about sort of when she decided to come out, and it was when she was living in our Michigan facility. Is there enough in here that allows or requires, let's say requires, your staff or any medical provider that ultimately gets the contract from initiating, let's just continue with an HRT example, upon realization that that is what's required here according to gender affirming care. And then part three, do we need to include any language that would continue that care upon release? Right now, it's a 28-day supply of medically necessary medications has to be provided to the person upon release. Are we covered in those three sorts of scenarios?
Yes. So partially from this and partially from existing statute. So the existing statute requires that we continue all medication a person is on in the community unless there's a medical indication and it's decided on by a provider and the rationale is documented in the chart.
Okay.
So if somebody is on estrogen and they have a big blood clot, I could imagine a scenario where we might say, look, we have to stop your estrogen right now. Not because we want to stop your estrogen, but because in this particular case, we need to make sure it's safe to continue HRT for you. That's just an example. I don't know that that's ever happened, but so once you actually see the provider, though, that's in the window before you see the provider. Before you see the provider, or once you see the provider, they can make changes that are consistent with good medical care and their own discretion. But this makes it pretty clear that we think, without saying you must continue somebody's HRT, which is hard because there's times we might need to not do that for a variety of reasons. But it makes it pretty clear, in my view, that if there's no medical indication not to, that was what we should be doing. Like, that's pretty clear to me. What happens to somebody outside Vermont that's still in our custody is not, I can't speak to that. So my apologies. That's not something I'll be able to speak to. The third piece, you were asking about release medicines. That's really taken care of by the 1115 waiver, which is going to move us to 90 days of medication.
Yeah.
And that really, we scramble high and low to make sure that's continued. An email I got just this morning regarding testosterone. Now, this is for male testosterone replacement, not for a trans male, but nevertheless, around injections. Like, how are we going to make sure that process moves smoothly? And the challenge there is that ideally everybody who leaves corrections should see a primary care doctor within a week or two. And we all know the barriers to that. But I think those three scenarios are covered by this and then two other, the 1115 and existing statute. So I think we're covered there from my point of view.
So for the language that's in draft 1.3, for what
Yes.
would be part of welfare, there's no flags there for you folks. There's nothing that brings up any questions that you would not be able to meet.
I think, Dr. Morrison, I don't know. I mean, having access, the biggest word, I love the word access because it means you should have access to it. But if it's not medically indicated, like we all have access to a CT scanner, but not everybody needs a CT scan, right? Like there's a conversation there that we're collaborating with our patient, all those things. The only thing about access, if that access doesn't exist in the community, and I'll use a hyperbole example here. What if UVM and Dartmouth stopped doing gender affirming surgery? Like, then is it our job to make sure, and maybe it is, maybe then we make a contract with Boston. I don't know what that looks like. So that's kind of a catastrophic example, and I think it's unlikely to happen. But so that's the only thing that's a little, but this feels very benign. Like, this is what we do already, or I should say, this is what we aim to do already. Can I promise it's happening 100%? Of course I can't, but this is what we should be doing. Dr. Morrison, do you have any, I'd love to give you an opportunity if it's okay with the committee. Any thoughts?
No, I thought the language was good. I mean, people, when they come in on medication, we continue it for any condition, including this. And then also for any condition, if they need consultation with somebody specialized, we make sure that happens. And that's true for gender affirming care too. To the question earlier about somebody who would start exploring their gender while incarcerated. I mean, that does happen, and when we do start HRT when it's appropriate, I mean, people get seen pretty quickly and taken seriously. And none of the language in the draft 1.3 holds us to anything that we're not already doing or that we shouldn't already be doing, for sure.
And I think I still have, and it's a very mild reservation. Like there's the piece we talked about before, the cultural competency. That's condition specific, but I know what is meant, and it doesn't have teeth that like I don't think, like, with the way this is written, I feel like I could totally work with, like, I kind of know what you guys want and what we're looking to hire.
So I've looked up the definition of cultural competency.
Yeah, what does it say?
It's specific to 18 VSA section 251, if anyone wants to go there. But it means a set of integrated attitudes, knowledge, and skills that enables a healthcare professional to care effectively for patients from cultures, groups, and communities other than that of the healthcare professional.
Yeah. And so if we want to geek out a little bit, which is fun, I'm happy to do that. The attitude, well, I don't want to say the easy part. It should be the easy part. The attitude is, gosh, this person has a different view of the world than I do. How do I collaborate with them for a treatment plan? The knowledge is where it might be culturally specific. And I used the example before, I have a great knowledge of the deaf community. I don't have a great knowledge of, say, a Native American community, right? But the attitude helps you build that knowledge. So I think this is fine. Like, this doesn't tie our hands in a way that we can't do what we need to do. It's clear what's indicated. I don't want to hire anybody that doesn't have the ability to do that. Say, wow. I mean, starting with the very act of being incarcerated, or the condition rather of being incarcerated. I screen our providers when we hire them. Like, what does this mean? How do you think people got here? Why do you think? What are they dealing with? What can you imagine? Why are they? Here's a specific one. People do funny things to get healthcare, and a lot of it is because of the condition they're in, because they're in this very weird state, and making sure they can understand that. So that's what we do. I wouldn't want somebody working for me that didn't.
And although I think we often think of culture as being, from national boundaries or subcultures within American culture, like the deaf or the blind communities, there is definitely a difference in the context that people are coming from when they're coming into corrections. There many of them, most of them, I would say, are coming from a place of deep trauma, with a lot of, and there's an openness and gentleness to approach that's necessary with medicine for those people. That is about cultural competency.
So two things. And the second thing is where I'll want to take us. The first thing is just more of a reminder of where we are, the context in which we're talking, but then I want to talk about your specific concerns about access, the word access, and if we can tweak that at all. But I am thankful and grateful and have a sincerely held belief that our approach to providing medical services in the Vermont correctional system is in good hands right now. That's speaking to you specifically, Dr. Uliger, because you've been in here a few times and getting a similar vibe from you, Dr. Morrison. We have to, though, make sure that we're securing this for the event that we change contracts and you two are no longer at the helm. So a quick question, are we set up to do that for the next contractor? Worst case scenario, a contractor who doesn't really care about this kind of stuff. Does this feel like we are putting together a code statute that sets those parameters in a way that maintains the consistency of what we're trying to do across contracts?
Yeah, no, and I think we all have to have a legacy plan. I absolutely agree. And I can only, so if I were, and this is not what I do for a living, but if I were hiring a new contractor, I would look at page 12, line 1, that's section 2 there, and say, how are you going to do that? And what does that mean to you?
Okay.
And that, to me, and I guess to also help you understand me a little bit, certainly we've been talking about details. Details are important, but it's, to me, the big picture is really like, if you don't have a good answer to line 1 on page 12, you shouldn't get the Vermont contract.
Yeah, okay. And then let's go to line 5 of that same page. And talk about access. Is there any language that we can tweak there that would just kind of alleviate that minor concern that you've articulated? Access, like, do we want to bring in community equivalent to a community standards kind of language? I'm fuzzy brained right now, so I'm not coming up with it off the top of my head, but do you understand my question?
Yeah, I do. I don't.
Not even.
Personally, I think this is fine how it is.
Okay.
Because there's already elsewhere there's a requirement to community standard.
Okay.
So I think it would be defensible to be like, well, you didn't provide access. It's like, because it's just not there. Like, we don't have it. You wouldn't have that.
Okay.
So I'm not an attorney. I'm not a lawmaker. But to me, I don't feel pigeonholed by this.
Okay.
In any way.
I would add that if you were to have a contractor come in who did not care about this, then language that should be in here that's not would be something about timeliness and scope. So I would, so you could say, shall ensure inmates access, consistent with community standards of timeliness and scope of care.
That's a
because
good.
You wouldn't want somebody coming in and slow walking it and being like, oh yeah, sure, we'll have somebody see you in 2 years or whatever, or we'll have somebody see you who is our one mental health counselor, who talks about this but doesn't actually provide any care.
Yeah.
Can you just repeat that language? Access consistent?
I would say from page 12, line 5, it says the department and its contractors shall ensure inmates access. And after access, I would say consistent with community standards of timeliness and scope of care.
Thank you.
Yeah, that makes sense. I like that.
Yes, very much so. So you'd add a new day or you see
Or just put it in that
Yeah.
line right on line 5 there.
Yeah.
Under 3, just what Dr. Morrison just articulated. I think that's enough, but we can have Hillary.
Or add it to A, maybe.
Sure. Okay.
So I have a question in the next section, B1A, which is when someone's coming into the facility. And right now there are requirements in terms of what you need to do within the first 2 weeks. What is laid out here in terms of physical assessment would include identifying any medical needs, and it deals with EOC and WellPath, assuming when it says the department shall not search or physically examine an inmate for the sole purposes of determining the genital status. How does this new language work within the requirement that within two weeks of someone being admitted to the facility?
I don't see an issue with that. I mean, you're going to continue your medications, right? The security, again, I'm not security, happy not to be security. If they have a question about a person's anatomy in that first 2 weeks, there are, and 14 days is an outer limit. We strive to do it a lot sooner. So if there was some acute concern and there were a medically appropriate reason for us to do some sort of physical exam that was a sensitive physical exam, and I really, that needs to be for medical purposes. It's not for forensic purposes. We don't do forensic stuff. But we could see somebody, if the question was, we're trying to house this person safely for their benefit and for others, can you put them sooner on the list for that? That's got to be, I would imagine that would be handled that way. So I think the wording is pretty good. I do think when I first read this, I was worried that the department could be construed to include the contractor. And again, I don't want the medical contractor doing exams just for this purpose either, but it finishes really well at the top of page 13 as part of a broader medical examination, which we'll be talking about, anatomy appropriate cancer screening, right? Using the anatomy inventory that we would do as part of an appropriate physical exam. And so that kind of tidies that up for me. Dr. Morrison, any thoughts on that?
I guess the only change, I'm really glad that C is in there for my patient's sake. The 14 days is consistent with NCCHC standards, which is, applies to healthcare, which is the standard to which provision of medical care and healthcare and corrections is held to in Vermont. So that's consistent. The only part of the language that seems not quite specific enough is about the broader medical examination. Let's say something about being more focused or appropriate, because it's not routine. Like genital examination is just not a routine part of a broader medical examination. It has to be problem specific or for a specific reason.
Well, if Dr. Morrison and I could make sausage before your eyes, and I read that, Jeremy, as like a broader, just as part, like we talked about this last time you were here, that security shouldn't be sending somebody to medical for us to tell them if they have a penis or not. The language that's written here to me says, if this is
You muted yourself.
Yeah, I did, right? It's what happens when you talk with your hands. If this is part of a general medical exam and we have that information and they need that to determine safe housing, fine. But we're not going to do that exam for them because we don't do forensic exams, and that's kind of covered elsewhere. So I guess I'm comfortable with either one. I think we're on the same page, but I don't know. Are you asking Dr. Morrison for something that's really specific around like medical doesn't do forensic exams?
Yes. I guess I worry. I guess I worry about the idea that, and if this may be misplaced, I guess I worry about the idea of somebody's anatomy being necessary to know for security, for secure housing. Like that seems inconsistent with much of what's in this bill.
Mm-hmm.
And so I guess just like we do not provide forensic information to security about people's medical testing, I would also not want us in a position to be put in a position to share medical information that security doesn't need. Because it seems like what this bill is saying is that security does not necessarily need to ascertain the genitals that somebody has in order to determine safe housing.
Yeah, and I think that's so. And again, not being in security, I think that's the controversial point, right? Because I don't know. I don't strongly disagree. And again, I'm not security, so I don't have a professional opinion on it. But to me, it does seem relevant. And what I see the bill as doing is as saying, like, you could do that without. So Kalani's experience was that they actually made her strip. They did a strip search for this particular reason, which is obviously that's not what we want to do. I guess the question from my mind, and this is where I am, I would enforce that same thing, and this gets to somebody else's question earlier about how can this piece of legislation outlast all of us, right? But I would enforce that. Do we need that legislated, or is that enforced by good medical practice, which is regulated too by, in different ways? But we already, like, if somebody said, like, well, can you look at this person so you could tell us what they have? I would say no.
So we're in the screening and assessment piece. Okay, so this is when someone's in booking. in current law, within a minimum of 2 weeks, each inmate would be given a physical assessment. So WellPath does that. And what do you do currently with that physical assessment? Is that given to the Department of Corrections for where they classify where the inmate goes? Or is that kept internally within WellPath and providing healthcare to that person?
Yeah, that's a good question, and I don't know specifically where, because there's mobility codes. There's certain ways it's coded. Some of that, and just to be clear, that exam that occurs in booking is often a nursing assessment in booking, but whether the nursing assessment or whether we get to the initial H&P with the provider, neither of those, as Dr. Morrison was saying, neither of those include a genital exam,
Right.
unless there's I'm worried I have warts or something, like then it would, right? If there's an appropriate indication.
Or something.
Right, exactly. So, Dr. Morrison, are you aware exactly how that information is shared with security from the booking?
I'm not. I know that they have access to, so I don't know what access they have to the electronic health record. That electronic health record belongs to the Department of Corrections, and it's maintained by them, and we use it. And I know that you mentioned mobility codes. You know, when they are in booking, if there's any question about their mobility status, they're assigned a certain mobility code, which is like pending. You know, which is like mobility 3, and then when they see a provider during that initial health assessment within the first 14 days, the provider then determines their mobility and their ability to use a top bunk, etc. And I know that is accessible, but I don't know if they can access the electronic health record directly.
Well,
I think that is provided by the health services administrator to the facility.
Well, and the health and wellness team on the DOC has access to that, but security should not be routinely looking for medical information.
I guess the part of the language in section C of that screening that just seems a little off to me is that if the inmate's genital status is unknown, it may be determined during conversation with the inmate. I mean, it may be determined for medical purposes. I guess it seems very vague, as if it may be determined, for the purposes of security to know, and that just seems overly vague.
And I guess, and this is, you'll have to talk, and I know our security colleagues were there, Josh, and forgive me, I'm forgetting our PREA coordinator's name, but they gave some pretty powerful testimony. It seems to me that the genital status is relevant to safe placement, but if other people disagree and there's a reason, that's not something I feel expert in, right? That's not my, so if they feel differently, then I think that we could do something different there.
I'm stepping way back. It seems to me that an individual that is being booked that has female genitalia but identifies as a male is in considerably higher risk if they're put into a male facility, because we're not sharing that information with the people making the decision as to where they're being housed. If we can't assure safety for people in our custody, that to me seems like we're literally putting them at greater risk than 90% of the males that are in that facility. And so this conversation seems, forgive me, it seems absurd that the people who are making the decision as to where they're going to be housed wouldn't need to know what the current status of an individual is.
Yeah. And that I'm sympathetic to that point of view too. And I think I reflect on, I've learned a lot doing this actually with you guys. So I appreciate it. I heard two different things, one from Kalani and one from our DOC colleagues. And our DOC colleagues were saying that whatever gender you are, you can hurt somebody else. Whatever parts you have, you can still hurt somebody else sexually. So we know, for example, our male incarcerated individuals who are a smaller build and maybe don't shave as much and don't look as masculine are more likely to be taken advantage of sexually, whether they have a penis or whatever they have, right? So that was their argument. Kalani had a slightly different argument, the way I heard it, that she really felt like, actually, this is really important. We want to keep people safe. And we have had people request to be in Chittenden so they could make people pregnant. Like, that's been told to us. They're like, I want to make as many people that are pregnant as possible. And like, come on, like what, like that, like, I think we can all agree that that's not the right thing. Right. So that doesn't line up with that person's, and maybe it does if I'm displaying my own cultural incompetency, but it seems to me that that person did not have a motivation of being gender affirming. They had a different kind of motivation. Right. So I would, I think it's difficult, but I personally like the way it's written, but I feel like it gives us the wiggle room. But if Dr. Morrison, I would respect your opinion too. So if people feel like it needs to look different, then.
I'm not speaking to safety. I'm just worried about being the language being interpreted in a way that we would be asked to determine gender status for people.
And I'd have that same concern.
Yeah.
And I think we talked about that last time, is that we would say no. I don't know if the language needs to change such that we can't be asked for that purpose. So we're only maybe it would be as simple as putting in a phrase that says medical should be doing things only for medically indicated reasons, and any other information. So, and here's maybe a process thing, and I don't know if this belongs to legislation either. Like, it would feel better if security really had a concern about the safety of somebody, and the general status was relevant. And maybe the best way to think about this is it might be condition specific. Like, it might depend on the circumstances, right? I actually think they should go to health and wellness for that information. Who have access to our records, but they shouldn't be coming. And this has happened before, where security comes to my night nurse or my provider at the site, and then they're in a funny position. But if they go to their colleagues in health and wellness, that seems a little bit better. And if we've documented, we have, and if we haven't documented, we haven't.
Sorry.
I'll just draw your attention to the definition for medically necessary, line 11, page 13, because I think that gets at what you're asking for here. And then, do we need to be better about using the term medically necessary within section 1C?
Yeah, and I had read 5A on page 13. Would that help in 1C? On a broader, so we could, line 1 on page 13, we could say information as part of a broader medically necessary examination.
Yeah.
That might be a nice way to tighten it up.
Yeah.
Because you are referring to the definition. And I know when we did this definition of medically necessary, we got a lot of testimony doing this because we knew it was going to be used throughout the whole medical system within DOC. So we spent a lot of time as a committee on this particular definition.
No, it caught my attention too and I don't want to take us sideways, but we get, we have to stick to our formulary, but I can approve if it's medically necessary. And I wrestle with that all the time. Like, well, what does that mean? Right. And so again, I don't want to take us sideways, but yeah, it's a poignant term.
Right.
Deserves the gravity.
Because that determines all your medical care that you provide. It determines the basis of someone if they're on MOUD. It's the whole gamut.
It's all of it. Yeah. And it's very, yeah, it's a big word. But I think that I think that asks for some of the tightening that Dr. Morrison, and that would make me feel better that we're only going to be asked to do things that are medically necessary and not forensic.
Great. Welcome to reading law.
I know, right? Oh my
A little
God.
different than what we normally read in our everyday life.
Well, I do appreciate, I mean, this feels appropriate time to express my gratitude for being allowed to be included in this, because I think I've learned a lot, and it's helpful to be able to participate in how our patients can get good care, even after we aren't here.
So with particularly that particular change, and we didn't really make any change to the top of page 12. You're comfortable with the language as drafted there?
I don't have
On
anything
page
to-
12, we did add, I'm sorry. On line 5, department contractors would ensure inmates access is consistent with the community standard of care for timeliness and spokeness of care.
With the possibility of inserting that into 3A instead of 3, yeah.
And then connecting in terms of the physical assessment within the first 2 weeks to add at the top of page 13 in terms of that medical examination, that it's part of a broader medically necessary examination.
Yeah.
To really be clear, it's medical, not for placement of a person. In the
Yeah,
facility.
that feels good. Yeah.
Questions of the committee? So you folks are comfortable with the current language with those 2 changes? It's too easy.
Not going to make my world any different. Well, because we should be doing it already. And we mostly are. And obviously, it's always the outlier cases that test the thing, right?
Yeah.
Right. Mm-hmm.
And this would provide enough assurance regardless of what contractor we contract with.
Yeah. At the risk of adding something now that we've all talked about that, I wonder, and Jeremy, when we were talking about this earlier, referred to this. I don't know if it should require some for 12, page 12, the paragraph 2 right at the top, line 1, that it should mandate some sort of training. We've been asked to do that by the department already, and we've done it. But a lot of the mistakes I see people make is because they haven't been exposed to the words to use or the way to approach somebody. And I think that training goes a long way.
So to be specific, Dr. Uliger, are you talking about striking the first clause there?
No, I'm sorry. Page 12, the top 4 lines,
Yes.
where it talks about the cultural competency.
Yes.
I could imagine, and again, when it was too easy, so that you get what you asked for. Now I'm stirring it up again. But if you just add something like it's the contractor's duty to ensure. So this talks about shall ensure the use of providers. It sounds, the way I read that, it's like we're hiring providers who have this competency, which we should be, and we should also provide training to support that competency.
Would it be enough to change the order of the words, like to ensure the cultural competency of the licensed healthcare providers?
Yes, I think that would be a nice way to use less words and
Can
say
you
more.
say that again so that I can type it?
To
So
ensure
say-
cultural competency
Yep.
Of a licensed health
of a licensed healthcare provider with English, well,
Yeah, can you
That
restate
changes the
what you
emphasis,
said,
yeah.
Dr. Morrison? If you can remember. So the contractor would do the training or the department?
I think it should be the contractor, personally.
Yeah, it's
And
their
I'll
duty.
tell you, when the DOC asked us to do that training here, WellPath developed a training that they're now going to use all over the country. So that's a nice thing.
So would it be as simple as saying shall ensure and train the use? No, it doesn't work.
I would suggest the department and its contractors shall ensure the cultural competency of its licensed healthcare providers to administer healthcare services. ...
Yep.
So if you're hiring an expert, great. If you're not, fine. You just got to train them.
And we have done both.
We have. That's true.
Sometimes the training is enough, and sometimes you need to bring in experts.
Right. Yeah, we've done both.
So you flip the words and it changes.
Yeah.
Yeah, I like that.
The emphasis, yeah.
It is 11:18, doesn't he have 11:15, 30?
So you have that, Troy, right? I've got it too in a scribble. So it would read, contractor shall ensure the use of the cultural competency of its licensed healthcare provider.
Can I put it in the chat because it's a little different than that I think would. I'll put this suggestion.
You broke up a little bit, Dr. Uliger. What was that?
I'm going to put it in the chat, my suggestion.
Oh, all right.
Um,
And Tate, you have access to that, right? Anything else that folks can think of? So what we can do, we can get another draft. We can get a draft of this proposed language for page 12 and 13. Work with our legal counsel, get a draft, and send that to you folks electronically to look at it and give us the sign off, yes or no, that it works. And then we can then come back to our legislative world to see if we can find a path to put it in H 550. That makes sense to folks? Because it's over in the Senate.
Yeah, this work today.
Anything else from both of you, Dr. Uliger or Dr. Morrison? We appreciate you making the time today.
we appreciate being here, and thanks for including Dr. Morrison.
Yeah. Any questions, further questions for the committee? Thank you both. We
Yes,
really
thank you.
appreciate it. And you will be receiving probably an email from Hillary Chutter Ames. She's our legal counsel. That will be who you'll be receiving an email from with the new language.
We'll look forward to it.
Okay, hopefully this week, should be this week.
Thanks, everyone.
Thank you.
Thank you.
Thank you.
Okay, so for the committee, John is tied up with the deal bill. So he was gonna give us a walkthrough of the capital bill. Do we have a draft?
I have the language for it, and he said also he's available after the House floor.
After the floor,
Yeah, after the House floor.
so we could wait and the house floor. So we really don't have anything. Right?
Right.
Let me do that. I know that, jumping around here. Here. So Tate, if you could just get an email to Hillary, so we really spend some time, and then we need to talk to her for some language.
Sure.
We're working on. And I would ask for Troy, maybe, oh, Troy, you took the notes, I took the notes, anyone else take the
I
notes?
took a couple notes.
Okay, the three of us could sit down with Hillary, just go over that, so she can do it in draft. Katie McLean did a new draft with Eric Fitzpatrick on H-193 that is being presented, I think, I'm not sure if it's already been presented.
I saw her this morning having
Right.
presented.
Representative Dolan said they were talking about.
Yeah, for House Judiciary. And in H-193, everywhere where it said Department of Corrections got substituted for the Secretary of the Agency of Human Services. So that's just a preliminary, that's what they were gonna present to House Judiciary. I can send that out to you. She sent it to me to quickly read. I can send that out to you, but I don't want to confuse.
Oh.
So I don't want to confuse you with another draft. I'd rather wait. See what judiciary
Are you
did.
kidding me? You're not going over to your desk that we keep there open for you all the time?
That's a good point.
He's waving
It's
them.
actually clear.
So I decided to wait on that draft before sending it out to you because I don't want to get any more confusion until after the judiciary committee looks at it and then Eric and Katie and Martin and I were gonna meet at 1:00 as well to go through it, so. Trying to.
For what it's worth, and just for your information, Katie's also presenting after the floor, second piece of testimony to Human Services. This afternoon.
She's freed up. We've been working on
Right.
it.
I guess I'm suggesting we could observe that if we wish to, if she
Yeah.
can't be here, but.
Yeah, but I've been working, I've been getting emails, well. Yeah, she's got a little bit of language too that she wants to go over with us in terms of the feasibility plan and that structure. So she can come down for like 15 minutes this afternoon after the floor, before upstairs. And we can watch it. It was fun to watch Human Services a little bit this morning for them. I mean, they're all looking at 193 upstairs and we can watch that if we have to as well. Connor was sitting at the table upstairs, Brian.
Oh, I got invited to the table too. I just didn't make a big deal about it.
The thing that was frustrating Connor is he couldn't ask any questions.
She invited me to ask questions. I declined.
Well.
Maybe she didn't want to hear from Rep. Casey, I don't know.
yeah, you know.
Maybe it's a backstory.
Maybe.
Okay. Capitol Bill, haven't seen you in a while, Todd.
Hello.
How's it feel to be back here?
Great.
Damn.
Damn.
Tired, feeling
We're
so.
pretty simple people.
Yeah, I'm not gonna.
I'm just a simple man.
We're simple-minded.
We're
What are
very
you, what are you
simple.
saying?
So simple, I'm just stuck on Snoopy over there,
Thank you.
It's.
thinking about the original Snoopy, Scott,
Oh,
the original color of Snoopy's goggles was blue.
Okay.
I feel like council's getting all the love. Hi, Scott.
Good morning.
how many spreadsheets are you doing anymore?
Yes, in fact, he would. For the record, Senator Greg Fiscal, Senator Harris would like me to, for the presentation to the Senate floor, another variation of the colors. This color is the only change, though, I mean, okay.
Oh, well.
But
Oh, we're live.
Did it come out of approach yesterday?
approach tomorrow, Thursday.
So it'll be on, so it's coming out of approach tomorrow.
Correct. And so then,
Notice Fridays, it won't be up until next week on Tuesday.
the Senate floor, I believe maybe they're doing it today, but they still have a yield bill to get through. That might be today, right now, I think maybe. Yeah,
Yeah, it's any second, which would cause me to make this run.
So they might get the yield build out.
Yield
Finance.
bill is on the floor today, any minute, yeah,
Oh, okay.
which is why I'm here, but could leave at any second.
So why don't you get started?
Yep.
Real quick. Because there isn't much language change. I know we got all the numbers. I'm not
Exactly.
worried about the numbers so much. I more wanna see what they've
Sure.
done for language. That's all I'm concerned, because the numbers we already went through.
That is perfect.
Keep it simple.
I am John Gray, the Office of Legislative Counsel, and again, Scott has made my life much easier. I'm very appreciative for that. And you guys have given me candy.
Yeah.
Appreciative for that.
The committee's giving candy?
I mysterious, it's not that mysterious given how I live, but everywhere I go, people give me food. And it's nice. It's nice. So the thing that I will tell the committee, it's in instances of
Oh, that's
amendment.
right. This is
It's not a strike all. I think you guys are accustomed to seeing strike all. And in the end, this frankly would have become a strike all had I had more time before the vote. There was a period during the week in which the changes were sufficiently limited that it actually would have been advantageous to have a strike all. And as you know, for conference committee, it would make much clearer where there are actually disagreements. And so hopefully it could accelerate the process. By the end of the week, it had grown much larger, and I just really didn't have time to convert it to a strike all at that point with when the vote was occurring. So I think it still may be helpful to have this in the form of a strike all because you can see where there are differences. But that said, it's not as obvious as just looking at it because, for instance, the Senate has to take the House's position and propose changes, right? So you may see things within a section that are reflective of the House position and only one thing is the Senate's position, right? Because you can't strike out and replace it with just the Senate's position. That would eliminate all the underlying pieces. Given what you've said, I'm not going to hit too much on the money pieces. The one thing I will hit is section 1. So first instance of amendment on page 1, you'll note a larger aggregate figure here, the 123 million. I'm sure that Scott spoke to this, but because a later section reallocates some old funds, the Senate operated within a larger box. They pulled in more bonding dollars to the bottom line. On page 2, there is a language update to subdivision 12, which is the line item for the State House entryway upgrades, design docs, comprehensive parking plan, etc. In addition to the dollar update there, which I think went up by 25K, I want to say, you see the new language of and second floor fire escape design. I do just want to note what you're going to see once this leaves the Senate floor is it will say second floor egress design.
Second floor, what?
Egress design, which is intended to be a broader call out than just fire escape.
Yeah.
So just wanted to note that there is this expansion of the purpose of the subdivision 12 line item. So in addition to those entryway upgrades design documents, you now have a sort of unrelated, it's still part of the State House, but sort of unrelated second floor egress design.
Who's putting in that egress thing? Institutions or approach? Which one's asking for it?
it was a request from Sergeant Environment to
Okay.
talk about egress for the second floor, really. Realistically, the Senate chamber, but also just the second floor in totality. So that really started with Sergeant Environment.
And if you're asking how the change from fire escape to egress is happening, probably more of an offline conversation, but
This is really. Conversations and conference tonight. Because this really ups the price of the project in it. If you really do an egress properly to the second floor, you're reconfiguring the Senate from. You're refiguring the House Transportation Committee and the House Ways and Means Committee and all of that.
Depending on how expansive it is, right? Yeah, you could view this as while there are additional dollars available because they've expanded the scope of the line item, you may see a reduction in dollars that actually go to what the House's position was, right? Because if you're using more than 25K of this 1.325 for the second floor egress design, then you will have less than 1.3 billion for the remainder. I don't know.
That ups the project cost
In the future, yeah.
in the future.
Okay.
And we really have to balance. I'm just putting this out on the table, folks to think. We really have to balance putting money in the State House for security upgrades and access to the building. When we've got a lot of moisture issues within the structure of the State House. We're looking at the granite that's out there with the water coming through, and the cost of all that. So that's what we're gonna have to balance next year. Just putting it on the table for people to think about a little bit. Okay,
All right. Let's see, you're gonna see some new lineup. I mean, Scott's already spoken to this, but on page 3, you're gonna see some new language, but one of the pieces I did want to call out is this Newport Northern State Correctional Facility sprinkler system rates. This is probably more obvious to you guys because you work primarily off of the spreadsheet. This is not a 500K reduction. This is just a change in the form that the dollar's taking going to the project. It's been converted to cash in this position. I'm going to skip over the 700K for the boiler replacement. They, as you can tell from Scott's presentation, I'm sure, wanted to align much closer with the GovRec on what to dedicate to the boiler replacement. The new pieces I really wanted to hit were 7 and 8. Recovery House Inc., 220K residential treatment center renovations. As you'll know, this is sort of different than many other line items. It's not going to a state entity, it's going to a nonprofit. My understanding is that there is some precedent for this. I think the 2018 capital bill had funds dedicated to the Serenity House, which I think is a specific facility operated by this group, if I recall correctly. In any event, these are funds going to the ownership group for renovations at residential treatment centers.
so looking into this, it appears the Serenity that's maybe under the agency of Human Services.
You're wondering if there's a different way to direct it?
No,
No.
they were more of a state operated facility licensed by the state, where this recovery housing is on a separate contract.
So it'd be
I'm not
worth,
sure.
yeah, it'd be worth talking to these folks, but I want to say that there's a relationship between Recovery House and Serenity. And I just want to say that I think Recovery House is like the higher structure. So if that is what comforted the legislature at that time, it may also extend to the same piece, but worth thinking through, yeah. The other piece here, and this is what, sorry, I keep having to check my updates, make sure I'm not being called. Subdivision 8, this is, while we talk about money going to the bottom line and being available to all projects, I'm just going to say for purposes of this one, the roughly 600K you see dedicated to this line item 8, maintenance, replacement, and renovations at the Chittenden Regional Correctional Facility or other facilities serving the incarcerated women's population came from the additional reallocation that they did. They took funds from that were dedicated exclusively, older funds dedicated, I think it's 2021, dedicated to replacement women's facility, right? And then they took a portion of that, dedicated it to making the boiler replacement up to the 1.7 million total. And then the remainder of the balance, this 598,850, is dedicated to a slightly expanded purpose. So instead of just replacement women's facilities, they were trying to address sort of imminent in this year needs. So maintenance, also replacement if you can get to it, and renovations at the Chittenden Regional Correctional Facility. And then additionally, they wanted to call out all facilities serving the incarcerated women's population. So reallocating dollars from an older project dedicated to replacement women's facilities and then expanding a little bit the purpose and essentially refreshing those figures. But as I understand it, the dollars would have needed to have been reallocated next year anyway, so this sort of grabs them a little bit sooner.
So do you know what the total amount was between number 6 and number 8 for the total amount that was being reallocated?
It's 868,000.
It's 868,000. And what do they mean by or other facilities?
Yeah.
Serving
Yeah.
the incarcerated women's population, are those other, like Vermont Works for Women, Mercy Connections? Are we talking about facilities that the state doesn't own?
I don't think it's intended to be facilities that the state doesn't own, but again, I think talking with,
Would that include the other male facilities if a female was held for the weekend?
yeah, I think that is a fair, I think that is a good question because the language just serving
Oh,
doesn't say exclusively
Starting
serving.
a wing.
yeah.
Or other facilities serving the incarcerated women's population?
So renovating a
Well,
wing.
then it just
A
becomes.
wing, an existing facility.
Yeah. Just sales in the holding area.
It's other facilities, so it's other facilities besides the chicken.
And I'm sorry, but the yield bill just went up on the floor, so I should probably run. But I can, I think Kate has some of my availability. I can come back
After the.
late. Yeah, I think 3:30. I don't know when you guys are gonna finish on the floor.
We'll play it by ear.
Okay, I'll be checking
We
in.
miss you, John, we wanna get you back.
It feels very, well, I don't know what I can say live.
Not much.
I'll see you guys soon.
All you got was a Milky Way?
You guys are raising good points. I will,
Just wait until we get up the conference committee.
I am.
Can't
I am.
wait.
Yeah, Wendy will come in.
Troy, just to make it plain to Brian, forensic,
That's better.
What?
the language, the renovation of a wing.
Oh, that's it.
See you guys.
Good
and
night.
Thank you for
I'm thinking
understanding my ever ridiculous.
if they able to move all of them into.
Yes,
I see, that's what I'm wondering. Okay,
you would like some.
well, that's what I
Shoot.
when do you wanna?
I've observed guys' behavior patterns.
You too, folks. So I know it's a little early. Can't think of anything else to do. I don't really want to go through this without John.
Yeah.
For this. Brian,
Adam.
so S-193, you and Connor keeping
I'll
tabs.
get there this afternoon.
So they're gonna be, is it both human services and healthcare? Is that what's going on?
The only agenda that I know about well is human services. They have 2 pieces of testimony on S-193 after the floor today.
Okay,
The second of which is Katie McClin, the first of which, let's find out. Barbara Lee, co-chair State Program Standing Committee. Barbara Prine, attorney, Disability Law Project, Vermont Legal Aid. They're first, Katie McClin second.
okay. I was confusing Katie when she's doing healthcare, and freaked that out for her.
She may be bounced in various places. I think a lot of people are. Yeah,
Okay, so you've got,
I've got the afternoon
you got
upstairs.
the afternoons.
I do.
We'll get an update from Connor. Yesterday, what happened? You were in there, anything?
I think there was concern expressed by both of the witnesses that we are potentially talking about a lot of people in very different populations. And if I understood the chair's response, it was sort of like this testimony isn't exactly on point to the bill that's being considered. Anyway, much of it was about what is missing from the bill in terms of ideally serving this population. So different levels of care, including within the community, some version of step down, the concern about people being sort of like lost in the system for perpetuity if they're incompetent and within a correctional facility.
That's the whole issue. There's no process, there's no state program, there's no state process in terms of restoration of competency.
Correct. There was desire on the part of both presenters to have some sort of outside oversight that is not just within AHS.
About forensic facility?
Of what happens there, yes, or how this population is treated. Yeah, there was a lot of concern on the part of the presenters of the intellectually or developmentally disabled population. And how that population would fit into the confines of this bill or our correctional system. And the answer basically being they won't.
Who were the presenters?
They were Kelsey Stabseth, the director of Northeast Kingdom Human Services / Vermont Care Partners, and the retired director of Upper Valley Services, Bill Ash. Kelsey Stabseth and Bill Ash both seem to have a very long resume of doing this kind of work. Like all the way back to Act 248 in the 80s in one case.
So the initial focus from upstairs is the intellectually developed. I almost have trouble with this term. IDD, developmentally disabled teams.
There was one pull quote that I've got the notes that I've got, but when Stabseth was speaking, he talked about the need for therapy to be trauma informed, and the quote was, "and not correctional in practice or culture." Yeah, which I think is pretty clear in its meaning. Question of who's determining competency? I think we've had that answered here probably, but the example of Woodside as a concern about not having independent oversight. Reiterating the concern about not having step down pathway. We've heard here.
Yeah.
Right. How do you get from really secure hospital level, restrictive to, because you have to go for least restrictive, right? You're able to. And same point again, no continuity or no continuum between short-term acute care and a community level of care, and just a different way of stating the same problem. I'll keep looking through, but that I think hits the highlights.
Well, this morning they had, Jay Johnson was there, the commissioner of DOC, commissioner of Dale, so they were getting a little bit more into it today.
Oh, and there was testimony from, and this is Stabseth again, that what is being proposed would go against Act 137 of 2024. And in the context of that same comment, expressed the need for appropriate leadership to be AHS wide, meaning DMH and Dale would have to be included and not just DOC. That is about it.
That's helpful. So it seems like we've got 4 committees, but if 4 committees are working sort of in the same direction, which I think we are. At this point, I think that's good news. We'll see as it unfolds, but it's helpful for you folks to be up there. And I hope Connor can answer the question.
Well, and I'm curious about who all is in attendance today, because during the hour or so that I was up there, Representative McGuire had been elsewhere, returned just for the very end of the testimony, and I think was upset by what he heard.
Yeah, well, he was there this morning. We zoomed in a little bit. I mean, we tuned in a little bit. He was there, particularly for Commissioner Dale.
Yep.
So let's circle back after the floor. We'll fill in our time. But tomorrow we do have a field trip to the Historical Society. And they're expecting us at what time? 9:30. We get to get in here about 9 o'clock. You should leave here around a little bit after 9. It's over on Barry. Take a few bars and go over there. Parking is an issue.
Yeah, please let me a whole. This where to park.
Yeah, parking's an issue because it's up on a hill as well. Parking's an issue. But you're coming with us, right, Tate?
Yes.
Okay.
You wouldn't miss it.
So let's take a lunch break and circle back after we get off the floor.